Okay, afternoon, everybody. Welcome to the 2021 Statewide Provider Training. My name is Emily Stahl. I am the Customer Service Supervisor with the Bureau of Medicaid Operations in Claims. So I'm sure that we've talked maybe to some of you. We ask that you have yourself on mute and your camera's off. It will help with lag. So a little bit of the agenda that we're going to start with today is just a general overview of Medicaid. We'll discuss Prism. We will talk about provider enrollment, Medicaid information, med policy, prior authorization, the pharmacy program, and then we will end with the Utah Office of Inspector General. Like it says in the asterisk below, a copy of the presentation was included in your reminder email along with the Q&A document. So there is that you can use. Also, we will have a question and answer segment after each presentation. So you can certainly ask questions. You can ask questions in the chat. We will try to get to those as efficiently as we can. We'll go ahead and do that. 6 bureaus that are included in the Department of Health are Medicaid Operations, Managed Healthcare, Healthcare Policy and Authorization, Long-Term Services and Support, Eligibility Policy, and Financial Services. You will be hearing from some representatives from each bureau. Let's see, we're going to go ahead and start with the Prism Project. I would like to introduce Bridget with Prism. She will be presenting their portion of this training.
Thank you. Thank you, Emily. Can you hear me okay? Just thumbs up. Yeah?
Okay.
All right. Great. Well, my name is Bridget Convey, and I work in the Director's Office at the Department of Health. And we're going to talk to you about some Prism updates that we have. So the first thing we wanted to talk about was the background of Prism. Prism is going to be the system that's replacing MMIS, as you know it, the Utah Medicaid Management Information System. And this is going to be a multi-year project. It's been going on for years. We plan on implementing in early 2023. And updates to the provider enrollment components already happened back in June of 2020. So some of you are already in there and using Prism. Thank you. As far as the timeline goes, we are going to implement early 2023. Like I said before, these are the components that we are going to be implementing. They include managed care processes, prior authorization, member eligibility, claims adjudication, claims payment, member web portal, and Audit Studio, which is our fraud and abuse system. We've also made some really cool changes to the provider directory that we want to make you guys aware of. We added some new fields. One of them is public phone number. So this is a required field. It's intended for you to list your public-facing phone number that you would like clients to call in on. We are asking that you update this information as soon as possible, and we're going to need this information updated for each location, not just your main location. It needs to be all of them. So put this on your to-do list of something that needs to get done to go to the provider directory and update this stuff. Next is your public email address. This is going to be an optional field, but if you have a public email address that's forward-facing, please add it. I'm sure that your clients would appreciate being able to get in contact with you via email. But if you don't have one, it's okay. Don't worry about it. It's optional. We also modified a field that is already existing in the provider directory for accepting new clients. So this was already in the system for individual and sole proprietor applicant types, but we added it for group practices, facility, agency, organization, atypical agency, and atypical individual. So what we'd like you to do is to please go in and indicate either yes or no if you're accepting new clients or not. If you leave it blank, it will be blank for the clients as they're searching through the provider directory. So just know that if you say yes, they'll know that you're accepting new patients. Here's a screenshot of what the new windows look like in the provider directory. You can access your provider directory by going to prism.health.utah.gov and just make sure and complete all those fields. And don't forget to do it for each location. We do have a website set up at medicaid.utah.gov/prism, where you can find a lot of updates on what's going on pre-implementation with Prism, and you're also going to be able to find updates on what's going on post-implementation. We issue quarterly Medicaid information bulletins, or Mibs. I'm sure you guys know about those. Different articles related to Prism. We also have access to training on there as well. And if you are a Medicaid provider that needs help with enrollment, could you go back one slide for me, Emily? If you're a Medicaid provider that needs help with enrollment, please visit medicaid.utah.gov/PE-training. All right. So those are the updates we have for Prism for you. Do you guys have any questions that we can help you with related to this topic? Okay, we are going to be on the entire time. Feel free to enter questions in chat. We're happy to help you. And I'm going to go ahead and pass this on to Tiffany. Thank you.
Thank you so much, Bridget. Today, I'm going to be presenting the provider enrollment section of our slides. My name is Tiffany Scouten. I am one of the team leads in our customer service unit. New enrollment. In this section of slides, we show you what you will need to complete a new enrollment for Utah Medicaid. As noted, an application can be started by visiting our website. Next slide. In completing the new enrollment, you must select an enrollment type and an applicant type. If you are an IHS facility, please select FAO. While you are completing your application, always maximize your screen and don't hit the back button. Next slide. Okay. Please remember, as you are entering addresses, click Validate Address when completing. When completed, select Finish. Next slide. Complete all required steps and upload the proper credentials. Your application must be completed within 60 days from start, or it will be purged. Next slide. Revalidating. All providers are required to revalidate every 3 to 5 years, depending on their risk level with CMS. Letters for revalidation will be mailed to the correspondence address 90 days prior to revalidation cycle date. Providers can view their revalidation cycle on the basic information screen. Next slide. Retroactive enrollment. Requesting a retroactive enrollment can be submitted by emailing providerenroll@utah.gov. Please include a detailed justification statement with your request. Next slide. Prism Troubleshooting. We've included several common scenarios to assist in troubleshooting. We cover updating EDI and provider information, uploading documents, reviewing required credentials, defining relationship of owners and managing employees. It is required to complete the final adverse legal action convictions disclosure anytime a change is made to the ownership page. Also included is troubleshooting account administrator access, and with that, do we have any questions regarding provider enrollment?
Could you go back about 7 slides just so I can get that email address? You went through it really fast.
Oh, the email is providerenroll@utah.gov. Okay. Yeah. So we are actually going to move on. I'm going to be presenting the Medicaid information and resources section. Members are required to present their Medicaid card before each service. It is the provider's responsibility to verify the member eligibility, as well as determining program type, managed care plan, primary insurance, and copay requirements. Eligibility can be verified using Access Now, our eligibility lookup tool, or the ANSI 270-271 report. Next slide. The patient eligibility lookup tool. Accessing the eligibility lookup tool can be done by following these steps on our website. Under the Provider tab, select Patient Eligibility Verification, Eligibility Lookup Tool, submitting your credentials, adding the NPI and patient information, which will then bring you to the patient eligibility results. Next slide. Interpretive services can be obtained by going through the steps listed in these 3 slides. Medicaid offers traditional and non-traditional benefits. Each plan has a different scope of services. Please visit our website for more information. And with that, for this section, I'm actually going to hand it over to Trevor in our managed care department.
Could you please slow down quite a bit, because you're going so fast I can't even take notes.
Yes.
Yes, I apologize for that. All right. So again, my name is Trevor Smith. I work in the Bureau of Managed Healthcare at the Department of Health and Division of Medicaid. And managed care is a program, it's a healthcare delivery system that is designed to organize and manage cost, utilization, and quality. There's 2 different types of managed care programs within the state. There's a Medicaid and a CHIP, and they have separate benefits and covered services, but they operate similarly. Providers are required to contract directly with the managed care plans in order to bill for those covered services. The types of Medicaid managed care plans are ACO, that's Accountable Care Organizations, which consist of physical health, UMIC, which stands for Utah Medicaid Integrated Care. Now, this is a new program that started January 2020, and it integrates both physical and behavioral health. There's a HOME program. This is a Healthy Outcomes Medical Excellence, is what that acronym stands for. And it's a physical and behavioral health program. It's got very limited enrollment. It's designed more for children and people that have complex conditions, including autism and just different behavioral health conditions. And there's a dental managed care plan that covers the dental services covered by Medicaid, and PMHP. That's the prepaid mental health plans for behavioral health. And we'll go into more detail on behavioral health and the PMHPs later in the slide deck.
Can we ask a question?
Sure.
Go ahead.
Yeah, my question is this. Can a patient get supplies through the CHIP and also the Medicaid program at the same time? Like the same product? For example, a patient needs Pediasure, he's getting half of that from the CHIP program. Can that patient also qualify to take it from the Medicaid program?
No, currently how eligibility enrollment works is you'd qualify for one or the other. CHIP is generally lesser benefit, so and it's based on income and the status of the individual. That's all determined through our partner at the Department of Workforce Services, and they determine that eligibility component. So the person would either qualify for CHIP or for Medicaid. Does that answer your question?
Yeah, I've come across a patient that have both, and she's getting the ensure or the food from the chip, and she said that is not enough. She also wants some from Medicaid, and I told her you can get it from both. She has to call the insurance, and they call our company and said no, she's also qualified to get it through money in our Medicaid, but she's already getting it from the chip program. So that's why I asked.
Yeah, that's something that I'd like to talk to you offline about, just so we can get more details, because I'm sure we don't want to discuss that since it's PHI, the Protected Health Information. So if
Okay.
there'll be some slides following later with some contact information, and I'd be happy to work with you directly on that to make sure that we get that resolved. But again, it should be only one program type that the person would qualify for Medicaid or CHIP.
Right. Thank you.
You're welcome. Okay, and then again for CHIP, there's the managed care organization for CHIP that has the physical and behavioral health components, and then there's a separate dental plan for CHIP. You can go to our website to find out more information about all these different programs. Next slide, please. Here are the managed care plans for Medicaid. You can see the plan names, and then the second column has the plan type. We've got ACO and integration. So the plans that operate our ACO, physical health plans, also operate the integrated plans. There's 4 of them. They all 4 operate statewide. There's the phone numbers and the email, the web URLs to get more information about those plans. And again, if you're not contract with one of these plans, you need to reach out to them directly and enroll with them as a network provider. Even if you're enrolled with Medicaid directly, you need to contract with these plans in order to provide services to their members. Then, as stated previously, there's the home program and 2 dental plans, MCNA Dental and Premier Access Dental, and their contact information is listed there. Next slide. And as I just stated previously, that there are complexities around the prepaid mental health plans. My coworker Dave Wild is manager over this unit, and he will continue the presentation.
Thanks, Trevor. So similar to that last slide, this slide's small and you're not gonna be able to read it. So look for it in your slide deck to actually get the details out of it. So this covers all the counties in the state and what the prepaid mental health plan is. There are some nuances like in the Bear River catchment area and then in Wasatch. Wasatch does not have a prepaid mental health plan. They are all fee-for-service for behavioral health. And then in the Bear River catchment area, they have a split system depending if it's a mental health service or a substance use disorder service. So like Trevor said, if you're going to see a member in their plan, you'll need to contract with the different PMHPs for those areas in order to be reimbursed for those services. Next slide. And then I also have the behavioral health updates. So a couple updates that have gone recently. As of October of last year, we opened up behavioral health crisis receiving centers reimbursement. We have, I think, 2 or 3 that are enrolled now. It is available statewide, so providers are able to provide that service and be reimbursed for behavioral health crisis receiving centers now. We also have received a waiver, so adults 21 through 64 now can be seen in IMDs. IMDs are standalone psychiatric facilities, like a standalone psych hospital, like a Highland Ridge or Provo Canyon. Before, the federal laws would not allow us to have members there outside of managed care, but now we have a waiver so they can have stays in these programs up to 60 days. And then also our mental health residential programs for up to 60 days. So these are larger programs with 17 or more beds. And then along with that, our mental health residential program now has a bundled code for 16 or fewer beds. Before, you were billing each individual service provided. Now it'll just be a daily bundled rate. Next is our social detox. Was a pilot project for about a year just in Salt Lake County, and that has been opened up statewide as of April. So our ASML of Care 3.2 is now open statewide. And last but not least, our case managers and peer support specialists, when you're doing a new enrollment for them, they'll need to update or need to upload in Prism their certificate from the Department of Substance Abuse and Mental Health, verifying that they are certified as a case manager or peer support specialist. If you are already enrolled, you'll need to update that when you need to revalidate. You don't need to go in and do it now. You're certainly welcome to. Then any new enrollment as of July 1 will need to have that certification uploaded on their enrollment. I think that's it for me.
Thank you, Dave. So just as a reminder, these slides have been sent to you, or if we do need to resend them, we certainly can. Also, this is being recorded and it will be published. If we've missed something or we could be going too fast, we will get to you. There are several of you that you have raised your hand. I'm not able to see the chat right now. Hold on one second. Okay, doesn't look like we have questions now, but if you do have a question, go ahead and put it in the chat. We can try and get to it at the end of the sections. If not, and you need to email a question, I can certainly get my email in the chat. Go ahead and jot that down. Any questions that we don't get to, send those to me and I can get them to whoever the question pertains to or the bureau that it needs to go to. We can take care of that as well. So we'll go ahead and turn it over to Tiffany to go through the Medicaid provider manuals.
Thank you, Emily. The Medicaid provider manuals are a great resource for individual provider type information. We encourage you to review and become familiar with the manuals. Next slide. Medicaid information bulletins, or Mibs, are written to inform providers of any Medicaid program updates. They're released quarterly, but we do have special interim Mibs for out-of-cycle updates. Next slide. Accessing the provider manuals and Mibs can be done on our website by following these steps. Under the Provider tab, select Provider Resources and Information. Select Manuals. Utah Medicaid Provider Manual. Medicaid Provider Manuals. And here you'll find a complete list of our individual manuals. Next slide. You'll also find the Medicaid information bulletins under the Provider Resources and Information. Next slide. You'll select Traditional Medicaid Program or Archives. Next slide. And here will be a list of our Mibs grouped by year. Our coverage and reimbursement lookup tool is great for showing detailed information of coverage for procedure codes, dates of service, and provider type. Next slide. Accessing the coverage and reimbursement lookup tool can be done in our provider section of our website. Select Coverage and Reimbursement, Coverage and Reimbursement Lookup Tool, and here you'll submit your code, provider type, and date of service. Member cost sharing. Some Medicaid members share the cost for certain services. We have a copay chart linked here below. We also have a list on the following slide. The services listed below are exempt from copays. Note, non-emergent use of an emergency room requires a copay. Some groups are also exempt from out-of-pocket costs. Children under 19, individuals receiving hospice care, and qualified Medicare beneficiaries, to name a few. Medicaid members are responsible for certain costs, such as charges during a time of ineligibility, spend down, charges for non-covered services when agreed to private pay, in writing with the provider and copays. Next slide. Except for cost sharing, charges that are not the responsibility of the member are listed. Some examples are charges in excess of Medicaid maximum allowable, a claim or portion of a claim that is denied for lack of medical necessity, and a claim denied due to provider error. Next slide. Billing Medicaid members. Medicaid payments are considered payment in full. Medicaid members may be billed for copays and coinsurance, and even broken appointments when the provider has a policy in place to bill for broken appointments for all patients. As stated before, a member can be billed for non-covered charges when all 4 of the following conditions are met. This information can be located via our website in our Section 1 Manual, Chapter 7. Here's a copy of our financial agreement form, and this is located in our Forms section. Billing for emergency services provided to a non-citizen. Our emergency-only program has a very restricted scope of services. Once a claim has been submitted to Medicaid, it will be denied for needing medical records. You'll need to submit the emergency services documentation submission form along with the medical records. If denied for not meeting policy criteria, the individual can then be billed. Coordination of benefits. Provider must bill all other liable parties prior to billing Medicaid. Claims denied from Medicare as non-covered services should be submitted to Medicaid as fee-for-service. Include line-level payments in addition to claim-level data to Medicaid. Medicaid is the payer of last resort. We have provided the electronic mailbox submission payer IDs below, as well as a fax number to submit primary payer EOBs using our documentation submission form. Next slide. Void and replacement claims. Providers should submit their own corrections to claims less than 3 years old. Submitting a void replacement claim can be done so by using the associated claim frequency code and transaction control number as listed on this slide. Overpayment or credit balance. Claims that are more than 3 years old will need to be corrected using our payment adjustment request form located in our forms section of our website. 1 form is required per claim. All required fields must be appropriately filled out or it will be returned to the provider. Checks along with the form can be submitted to the addresses listed here. Timely filing. Medicaid's timely filing is 1 year from the date of service for new claims. Corrected claims can be submitted up to 3 years from the date of service. However, no additional funds will be reimbursed. In the case of Medicare crossovers, all claims and adjustments must be received within 6 months of the Medicare decision. The from date on a claim is used to determine the timely, with the exception of institutional claims, where the through date of service is used to determine time.
I'll just send it in a thingy. Do you want me to?
Grievances, appeals, and hearings. States are required to have a fair hearing system that complies with the provisions of 42 CFR 431 Subpart E. The department's hearing procedures are described in Utah Administrative Code R 410-14. This list offers the action that a hearing can be requested. Hearing must be filed within 30 calendar days from the date of denial. Next slide. Managed care entities are also required to have a grievance and appeal system. If a managed care entity makes an adverse benefit determination, also referred to as an ABD, they must send notice of the determination and explain to the provider how to request an appeal. An appeal request must be filed with managed care within 60 calendar days from the date on the notice of the ABD. If the appeal decision is adverse, a state fair hearing with the Medicaid agency may then be requested. A hearing must be requested within 120 calendar days from the date of the managed care notice. A grievance is an expression of dissatisfaction about any matter other than an ABD. Grievances may be filed with the managed care plan at any time. Managed care must address a grievance within 90 calendar days from the date the grievance is received. Next slide. As a reminder, our Medicaid forms can be found on our website by selecting Providers, Provider Resources and Information, Forms, Provider Form Directory, and here you will find all forms for Utah Medicaid. Next slide. Record keeping. Utah Department of Health follows the provisions of Government Records Access and Management Act, also known as GRAMA. Medicaid providers must comply with all disclosure requirements in 42 CFR 455 subpart B. All providers must comply with the following rules regarding records noted in Section 1 of our manuals. Providers are required to maintain accurate clinical records and are subject to audits in which findings could result in the recoupment of payment. If it is the provider's responsibility to maintain accurate clinical records as listed below. Next slide. Utah Medicaid Provider Training Center can be located on our website. We offer on-demand videos for instruction and training on varied subjects. Next slide. Electronic visit verification. Beginning July 1st of 2021, all providers of personal care services in Medicaid must be able to demonstrate compliance with EVV requirements found in the 21st Century Cures Act. Provider of home health services will have until January 1st, 2023 to comply with EVV requirements. Additional information for EVV can be found on our website at the link provided below. This concludes the Medicaid information and resources portion of our presentation. Are there any questions before I turn the time over to BHPA? Pebble, what's your question? Okay, Brooke?
Yeah, so I am new to Medicaid, and I don't know if this is something I need to call someone to speak directly about, but I'm trying to figure out the relationship between the state Medicaid and like a managed care provider such as like Optum or Select Health. So how do they work together? Is it two separate things? Like, are those like two? I mean, I know you're two separate entities, but it seems like there's a connection that I might need to come on here and find client eligibility, but then it may be an Optum client. And so now I'm doing kind of the Optum system, like their electronic system. So can you kind of describe how you work with the managed care and how we juggle that?
And Trevor, can you elaborate on that one?
I apologize. Can you repeat the question really quick?
Yeah, so I was just saying, so I'm trying to figure out how to differentiate your entity and what we're learning today from what I'm doing with like Optum or Select Health or Healthy You Medicaid programs. I'm just wondering how you work together. Is it like a joint relationship where I come in and I try to identify or I find out the client's eligibility through your system, and then it ends up being an Optum client, so then I transition over to their system of requirements or how that works? Are there some clients that just have state Medicaid and they're not affiliated with like Healthy You, Select Health,
Yes.
Optum?
Yes. So your best friend would be the eligibility lookup tool.
Right.
And so you would use that. So let's just take an example. You got a new patient comes in. You'd look them up. It'll tell you what their plan would be for physical health. They could be on Select Health or Molina. It would tell you what their plan would be for behavioral health, so the PMHP that they could have. There's also the option that they could have no plan and they would just be straight. They'd call it fee for service, and that would be paid directly by the state.
So like if I go to your lookup tool and I see that they have Optum, at that point I switch everything kind of over to Optum and I don't do any more reporting for that client through you. Is that correct?
Yes, it does get a little confusing because there are some services that are carved out and only paid directly by the state.
So like if we're talking about behavioral health, so I'm a therapist. So if I'm talking specifically about behavioral health.
Yeah, so an example for behavioral health that might be paid by the state is for services prior to surgery, like if they need to have a therapist or something, give a consultation to make sure that they're okay for surgery, that would be paid by directly by the state. Otherwise, it would be paid by Optum and you would
go through them. So is there a possibility that I would look up just like 90837 individual therapy code, and I'd look up a client and I would see that they are not covered by Optum or Molina, but this is just a state client, so I will be billing the state for that session?
Yeah, and you'd want to make sure that you check each month, because Medicaid, it varies month to month what they could have. So if you look up 2 months ago that they were on Optum, you want to double check and make sure that they're still on Optum prior to performing services.
Okay, so is the state almost like considered one of the managed care, like it's one option? They may have just state coverage, or they may have Optum coverage, or they may have Molina coverage.
Yeah, but in your case, since you're a therapist, you're going to be mostly looking at that PMHP component. Some of the PMHPs in the state are run differently, where they don't enroll any provider. They have their own in-house provider staff, and so you would not necessarily be able to bill if somebody's in Davis Behavioral Health or
Okay, that's helpful. Thank you. So I just always need to go to the lookup tool and see who their plan is through.
Yep, that's going to be your best friend for sure.
Okay, thank you, Trevor.
You're welcome.
Brooke, I also put my email in the chat. If you want to email me any questions, I work directly with the PMHPs, and I'm happy to walk you through that, and also our mental health provider manual.
Oh, thank you so much. Thank you.
Okay, thank you so much. With that, I'd like to hand it over to Lee with Bhpa.
One sec, I'm trying to get my screen turned on. All right, perfect. All right, to introduce myself, I'm Lee Johnson. I'm the medical policy manager with the medical policy team that lies within the Bureau of Healthcare Policy and Authorization. We're going to go through these slides and describe a little bit about what the medical policy team does, and then what helps us determine coverage of services. The Bhpa medical policy team is comprised of staff that oversees more than 20 programs, including medical services, dental services, vision services, transportation services, and DME. There's also additional, but again, that's just to name a few. Some of the functions of the team is to research and develop, as well as advise on medical policy coverage and then what limitations should be followed. One of the things that we also do is, as we develop the policy, is determine if we're in compliance with state and federal regulations. if we're aligning with clinical evidence-based criteria, and then what are the limitations for Medicaid. And then additionally, we do research and respond to stakeholder questions regarding policy, which the email for that questions related to coverage policy should be in the slides. Anyways, next slide, please. All right, so there's a hierarchy that we look at as the medical policy team as far as what influences determinations of coverage. Generally, we start at the federal level. The primary source we utilize is the Code of Federal Regulation. Specifically, most of what we look at is under Section 42 as well. We also utilize the Social Security Act, United States Code, Affordable Care Act, 21st Century Cures Act, anything that dictates what state Medicaids need to cover or do. And then after that, we utilize the state plan. The state plan is a written agreement between the state of Utah and the federal government, indicating what services we'll cover and which ones we won't. And then after that, we move down into rule. Utah Administrative Code, or it's also referred to as rule. These are legally binding policies. They define our policies. These generally go out for public comment before their implementation, but they represent the Medicaid policy. Next slide. All right, after that, we come down to the Medicaid provider manuals. Those manuals generally describe service coverage and limitations in greater detail. The language is a little bit more, I would say, layperson related, not as much legalese. And anyways, it just gets into a higher level of specificity. To help support that at an even higher level, there is the coverage and reimbursement lookup tool, which was mentioned earlier. This is utilized to demonstrate specific coverage related to codes. So if you have a general service, you would go into the provider manuals to understand if a service is covered or not. And then you would jump into the lookup tool note if you knew exactly what service you needed to look up, and you could look up a specific code in there. We also utilize forms, Medicaid documents. These are Medicaid documents for specific processes and service authorizations, which contain additional guidance and Medicaid requirements. So there is additional policy. And then we notify providers and other external stakeholders of these changes through the Medicaid Information Bulletin, which is released at least quarterly and sometimes with interim releases. But if we are going to make an update to policy as far as coverage goes, that information will be contained in the Medicaid Information Bulletin. Next slide, please. All right, so the Bureau of Healthcare Policy and Authorization, referred to as BHPA, medical policy team, continues to change their designated provider manuals throughout the year. We're always evaluating the manuals as they are and how we can better improve those. And that includes evaluation of coverage. The provider manuals contain the coverage policy and instructional information on how that policy can be implemented. And like already mentioned, any changes made to those manuals is published in the Medicaid Information Bulletin. Additionally, providers should be familiar with the administrative rules. Specifically, what applies to Medicaid is anything under R414, healthcare financing, coverage, and reimbursement policy. So if you have questions of where that policy is, you can always look there. And then any changes in the Utah Administrative Rule are detailed in the Utah State Bulletin. So that's another resource. If there's going to be any changes, that's public notification that there's changes coming up in the rule. We don't change rules as often as we change manuals or lookup tool notes, just because it's such, it's a longer process. But if we do public notification. Next slide. All right, new policy updates over the past year. Next slide. One policy update. Now this says effective 1/1/21 dental services for aged, blind, and disabled individuals, age 21 years or older, and TAM SUD must receive their services through the University of Utah School of Dentistry and their associated statewide provider network. TAM members and aged actually started receiving their services prior to 1/1/21 through the University of Utah School of Dentistry. Blind and disabled came on board on 1/1/21. But all three of those populations currently receive their services through the U of U School of Dentistry or their associated statewide network of providers. Next slide, please. One update that was implemented over the last year is related to reporting denture services. There was concerns related to members who lose eligibility while undergoing the denture service process. It's a multi-stage process where a member can start the process, which could either be teeth removal or moldings, but then lose eligibility prior to the completion of that service. So there was an implementation of how to report services where that is the case. And that is specifically outlined in the dental provider manual. It was also released in a MIB, Medicaid Information Bulletin, back in 2021, 1/1/2021. One second, I want to make sure I'm not missing anything. Okay, and that's reported with the denture code itself in conjunction with CDT code D5899. Again, if you have specific questions about this, it's outlined fairly well in the provider manual. Anyways, next slide, please. All right, another update over the last year or so was related to the sedation and general anesthesia policy in the provider manual. Primarily what occurred here is Medicaid aligned their coverage to require adherence to ADA guidelines and when appropriate, specifically for pediatric populations, additionally the AAPD guidelines. They're fairly robust guidelines and are comprehensive and are a standard across the dental community, which is why we adopted them. And so primarily what you'll see in the provider manual is that under the sedation and general anesthesia section, it points to the ADA and AAPD guidelines. Next slide. Another update over the past year was to the urine drug testing, code coverage, what limitations there are, and what that looks like. So this became effective in May 2021. It was updated to align with the ASAM guidelines, ASAM, that encourage individualized medically necessary drug testing with more frequent testing early in recovery and less frequent testing as the patient becomes more stable. Current policy has a limitation of 60 units or 60 presumptive tests reported in a year, with 16 definitive tests allowed each year. Next slide. Okay, so there was enhancement to the telehealth policy updates or clarification as we moved into the COVID. It was necessary to make sure that, or the public health emergency with COVID, we wanted to make sure that providers were clear on services that were covered via telehealth and any changes there. So Utah Medicaid does cover telehealth services as long as it's considered medically necessary, non-experimental, and cost-effective. There are no geographical restrictions related to telehealth services. Telehealth communication may occur through interactive audio or video transmission. Services can be provided between a member and a distant site provider when a member is in their home or other location of their choice. The distant site provider may participate in the telehealth interaction from an appropriate location. And then effective April 1, 2021, the telephone evaluation and management service codes were open to physicians and other qualified healthcare professionals, which includes the 3 codes you can see on your screen. Next slide, please. Okay. If you're a provider and you rendered services via telehealth, those are reported one of 2 ways. If you're reporting using the CMS 1500 for professional claims, you indicate that a telehealth service was performed with place of service 02 on that form with the service's usual billing code. And then for institutional claims, you report utilizing the UB0404 and you utilize the GT modifier for those claims that are on that form. Next slide. Okay. Tele Dentistry is also available for coverage. Tele Dentistry services are covered for eligible members statewide. Providers must bill the appropriate Tele Dentistry code, which is D9995, on a line in addition to one of the 3 dental codes. So limited oral evaluation, reevaluation, and reevaluation post-operative visit. The teledentistry code D9995 itself will be reimbursed at 0, but is an indicator to Medicaid that the service was performed via teledentistry. Okay. One thing we have noted is that there has been confusion regarding requests for out-of-state transportation. The policy in the Transportation Services Manual was updated approximately about 2 years, but there's continued confusion surrounding that. So we wanted to address that in this slide. Documentation for out-of-state transportation includes providers must fill out the out-of-state transportation request form. That is found on the form section that was previously discussed in this presentation. A letter of medical necessity supporting medical record and supporting medical records from a referring provider. Then a letter of acceptance from the medical facility that the member is going to be going to, as well as a letter of acceptance from the physician who will be treating the member. There needs to be a treatment proposal included with that, and then confirmation that the medical facility and physician are either enrolled with Utah Medicaid or are willing to become enrolled. If the provider is not a current Utah Medicaid provider, upon approval of transportation request, payment rates for services may need to be negotiated with Utah Medicaid reimbursement staff. I can tell you from the policy coverage perspective, out-of-state transportation to another facility is generally only covered when medically appropriate, medically necessary, and it's a service that cannot be performed within the state of Utah. Very limited services that require out-of-state transportation. Next slide, please. Additionally, all documentation should be submitted at once. If you don't submit it all at once, it delays the review process and the prior authorization process. Just making sure I don't miss anything here. Again, there's an out-of-state travel form, which is available at that web address. You can find it in the form section that was presented earlier, and additional resources for this are found in the Medical Transportation Services Provider Manual. Next slide, please. Any questions?
I have a good question.
Sure.
With regards to telehealth, our company is a personal care agency, and we have to abide by the EVV guidelines. But is telehealth available to us, and does that go around the EVE guidelines, or is that something that we cannot do that we should be doing in-home visits?
I think that's a great question, and I do not have an immediate answer for that. So what I can do is, let me take this answer back. I think it needs input from multiple people, craft a response, and then we can send that out.
Okay, and just to be specific, it's like the nursing visits. I'm the registered nurse and owner, but the nursing visits, you know, EVE, as opposed to the caregivers or CNAs going in every single day. So if the nursing visits were, you know, able to do telehealth, how exactly would we get around the EVE? Because that would take down our percentages, everything else like that. So,
okay. Just in response, just for my clarification, when you're saying nursing visits, are you talking about the nursing assessments that need to occur at initiation of services in every 60 days?
Yes. Yes.
Okay. Okay. I'll get back to you on that question.
Okay. Thank you.
Lee, did you want to provide your email, or did you want them to just email the questions to?
I am more than happy to provide my email. Let me put that in the chat right now. Actually, these questions are best submitted to the DMHF medical policy team email.
That'd be great if you could just provide that in the chat, and they can go ahead and send you those questions. I noticed that Tammy has raised her hand. Tammy, do you have a question for Lee?
Tammy, if you're speaking, you're on mute.
Or you could put your question in the chat, and we could get to you in a little bit.
I'll try to answer any questions in the chats as we move forward with the presentation.
That'd be great. Thank you.
Sorry, I finally got it it was froze up. My question is along the lines of the last one. I'm actually a contracted PERS and telemedicine virtual care provider in Utah. And so when I'm reaching out to the home health, hospice, home care programs, are there some kind of guidelines as well that I should be going by so that they can have services covered under their waiver, or is that strictly only if we're contracting with the provider as far as the physician or the hospital?
Actually, Lee, you're on mute now as well.
Sorry, I just wanted to talk without anybody listening. If that question's a little complicated as well, would you mind crafting an email outlining that so we can get a better sense of exactly what's being asked, and then send it to that email that I provided in the chat?
Sure. Yeah, because it took me 4 weeks to get an authorization for someone for just basic PERS that's on the Medicaid waiver because of the dance, and finally figured out that he was with the home program, and they weren't aware that the PERS and telemedicine is an authorized Medicaid service. So I sent them all the codes and stuff, and we finally got it worked out, but it was a huge process, and I just want to make sure I'm doing the right thing.
Because part of your question contains concerns related to the waiver, that's going to need input from multiple sources as well, and that's why it would be best if we had that question outlined in an email.
Okay, thank you so much.
You're very welcome. And then looks like, one second. Well, there is another question in the chat. It says, are travel services provided for patients in state? For example, we're an oral surgery practice and we are the only provider in a 3 to 4 hour radius. Some of our patients are having difficulty traveling to get to the office. Are benefits available to the patients? Who do they contact? So Medicaid has a contract with a non-emergency medical transportation company, currently designated with Motive Care. There are stipulations of when that is covered and when it's not covered. That's outlined in the Utah Medicaid Provider Manual specific to transportation as well. However, transportation, I can tell you, is a covered service for traditional Medicaid members that are going to medically necessary appointments, as long as the provider is also enrolled with Medicaid. Additionally, a caveat to that is there is a requirement that any transportation of a member to services has to be to the nearest provider capable of providing those services. I hope that answers the question. Perfect. All right. Was there any more questions for medical policy or BHPA?
Lee, yes, there was one. It says, will any dental codes that were covered and are not anymore be in the Mibs? This is from Becca Springer.
Yes, so there is always a section in the Medicaid Information Bulletin that outlines codes that are being covered and codes that are being discontinued for coverage. And with generally, there'll be a little description of exactly the reason why, or additional information is provided elsewhere in the MIB if it's pertinent to a policy change beyond just what the codes are.
And Lee, just to clarify, they can also check the lookup tool to see if those are covered, or you can use customer service. We can certainly look those up for you to verify if it's a covered dental code. We can help with that as well.
I would highly recommend utilizing the coverage and reimbursement code lookup tool. Even with the med policy, it's a resource that we use frequently. It's really going to let you know if a service is covered for your provider type. And if there's a question of coverage, you can always, like Emily said, call customer service. But that's my go-to, and most of the medical policy teams go to, just to start answering questions for providers. It's not a answer for everything, but it's a good resource. So,
Becca, you can certainly give customer service a call. We can also give you the date that it started to not be covered, so that you can maybe just jot that down so that you have that for your future reference. We can look that up in our tool for you.
Yes. Are there any other questions for medical policy team? If not, I will turn the time over to Annette with PA.
All right, thank you, Lee. So hello, everyone. My name is Annette Nguyen. I am one of the supervisors for the prior authorization team that is within the Bureau of Healthcare Policy and Authorization. And I will be going over the prior authorization portion of the training today. This first slide gives you an overview of who makes up the prior authorization team. As you can see, our staff has the perfect balance of professionals to get the job done. We have a great prior authorization team, and our staff makes up 4 different teams. We have the outpatient DME team, the home health team, the behavioral health team, and then there's a screen dental team. We all work very hard in reviewing prior authorization requests for Medicaid members while working with the medical policy team and providers. Next. All of this information on this slide is essential when starting the prior authorization process. So please go to the Medicaid website each time you need a PA request form or other form for the services being requested. And you can find the website at medicaid.utah.gov. There's a lot of useful information there. So by going to the website each time, you will help ensure that you're using the most up-to-date form
And please remember to fill out all required fields and submit them to the appropriate box. Anything that is marked with an asterisk is required. Remember, we only review requests for fee-for-service Medicaid members. So unless the request is for a carve-out service, we will only do it for fee-for-service. Please provide the correct contact information, like a name and a phone number of who we can talk to about a request if questions arise. And then we would like you to please fill out the PA request forms electronically when possible. It makes it a lot easier for us to look at the request and get all the correct information. And if you would like examples of PA forms that have been filled out correctly, please send an email to medicaidcriteria@utah.gov, and we would be able to get you some of those examples. Okay, this slide is about prior authorization reminders. So like I mentioned, the Utah Department of Health Medicaid website has a lot of useful tools and information to help with prior authorization. This includes checking member eligibility and looking to see if codes require prior authorization. You will want to make sure to visit this website and become very familiar with it. When sending in your prior authorization request, please make sure that the documentation you send in is current and relevant with all required documents, forms, and all consents that would be needed for the services. Under healthcare providers on the Medicaid website, there are a lot of valuable resources. This is where you can find the Medicaid manuals and Mibs, the lookup tool notes, and our new online transparency tool, among several other things. This next slide talks about what's new in prior authorization. So we have recently updated the PA request forms to try to make them as similar as possible, but also to individualize them for the different programs. Each form also now includes a statement on them of what to do in case the request needs an expedited review. So please follow those instructions. You may have also noticed that we have changed the fax numbers and email addresses, and this was done to make it easier for the providers to know where to send in requests. We have also added several new forms for different programs, and they are listed on this slide. We are in the process of making our correspondence letters more user-friendly. We've already done that with our return letter, and we've been sending that out for several months now. We actually attach the return letter now to the fax or the email because it's it's in a lot better format to read. And we're hoping that this will help create better communication for the providers. And then I also want to point out that the PA team strives for a 7-day turnaround for routine PA requests. And we've been working very hard in the prior authorization department to get everything caught up because we have been behind. And I'm happy to report today that we're about 8 or 9 calendar days as of today. So we're getting caught up for you guys. Let's see. The next slide is about the Interqual transparency tool. So I saved the most exciting news for last because this tool is going to be very beneficial for a lot of you providers. This tool will assist you in knowing what documentation is required for prior authorization requests. And it needs to be used in conjunction with other Medicaid policies and resources. It was available as of July 1st. You need to go onto the website and register for the tool. And after you sign on, you will have access to the tool to view interqual criteria for many different services. I just want to remind you guys that not all programs use Interqual, but several programs do. And so this will be a great resource for you guys. It has a read-only criteria in there, and it's the exact same criteria that we use and put your documentation up against to see if it meets criteria. And that is all from prior authorization. So I just want to open it up for questions if anybody has any.
I actually have a statement, if that's okay. Excuse me. I've been working with with your department for the last 5 years, and now with the new way you're receiving information from us, Annette Leonard told me that this little trick works out better for you guys if providers are able to do it. When we submit email or fax in things that are separate files, say a PA form and a 485 and a doctor's note or a doctor's order, things like that, the way your system works is you have to actually open up different windows to look at all of them at the same time.
Mm-hmm.
And we've actually been doing where we use an Adobe program that allows us to not only fill out the PDFs quickly, but then we can also combine all the forms into one PDF, then submit it. Then the prior authorization team can look at all in one window, and it saves them time.
Thank you so much for that, Brett. I appreciate you sharing that. And I did notice when I was looking at everybody that was on the call today that we do have one of the screeners on the call. And, you know, I don't want to put them on the spot, but I don't know if they have anything else to add to that, because I know for a while we were having a problem the way some people were sending in the faxes and all of the clinical documentation. So that was very helpful. Let's see.
Thanks, Annette. Hey, I just wanted to mention that customer service does get an updated email where prior authorizations stand for dates of reviewing documentation that you're sending in. So you can certainly give customer service a call and find out where your imaging PA is. If it is, let's say it's 8/1 that you submitted those and they're not working and they're working on a date of 7/25, then you'll know that you will have to wait a little bit longer. But customer service can provide that for you.
Yes, thank you, Emily, for telling everyone that, because it is very helpful for us. Instead of, you know, tying up the nurse reviewers with questions of like what day we're working on or if there's a PA in the system, customer service is there to help us. So it helps free us up so that we can review.
And a question for you.
Okay.
Yeah, my question is this. If someone submitted prior authorization and it comes back says Auth not required, and when you submit the claim, it will deny needing Auth, and then when you call and they will say they need that Auth number, because most of the time when the Auth number says prior Auth not required, it does not give you that prior Auth number. I don't know what to do in a case like that.
Okay, so a couple things with this, and I'm actually going to have claims help me with this also. But first of all, like I had mentioned before, our Medicaid website is very useful for information like this. You can look up any CPT code or HCPCS code online, and it will tell you whether it requires prior authorization or not. So that's a very good resource for providers and staff members to go ahead and look up those CPT codes or HCPCS codes, first of all. And then, you know, we do run into that every once in a while in our program. A lot of the times, if PA is not required for a certain code, but then the claim is denied, sometimes these edits are, there's different edits that it hits. And this is where I'm going to ask claims to kind of jump in and help me, because I know sometimes it will say no PA required or that there's a prior authorization issue, and sometimes it doesn't always end up being a prior authorization issue. It ends up being a different edit. I don't know if somebody else can help me with that.
Hi, Annette. So what happens is there are some circumstances, a lot with anesthesia, where it will deny for needing an authorization. However, we can take a look at those claims and see that the surgeon's procedure doesn't require an authorization. We can go ahead and enforce those claims. But there are certain if you'd like to send me your question to my email, I can specifically look at your claim with you and find out what the situation is. But yeah, there is some things that do require an authorization that we can have a workaround with, but it is very specific things. So if you want to go ahead and send it to that email that Tiffany provided in the chat earlier, the estall@utah.gov, shoot me an email. I can set up a call with you. We can go over your claim and we can go from there.
Okay. Thank you. I did see Michelle had left a question in the chat. It says, did you say that you are the supervisor over behavioral health prior auths or all Medicaid prior auths? So there's a manager of the prior authorization department, and then there are 2 supervisors. I am the supervisor over the outpatient DME team. Nicole is over the behavioral health team. So is there a specific team that you were looking for, Michelle, or a specific program that you needed help with? And then just looking ahead while we wait for Michelle to answer that, there was a question from Becca. Who do I contact, or where could I go to get enrolled for Premier Access Medicaid prior auth for dental? Is there anybody in enrollment that could maybe help me with that one? Because I don't really help with the enrollment process.
I wonder if that would be a question for managed care, that they could help them get in touch with credentialing with that managed care.
I can help. I can help with that question. Can you just repeat that one more time, what the question was for who do I contact?
Yes, it says, who do I contact, or where could I go to get enrolled for Premier Access Medicaid prior auth for dental?
Okay, I will put that email address or their website in the chat box, and you would just go to that website and they'll have prior authorization information as well as provider enrollment information on their website, and you can do it online. And so I'll put their contact information in there.
Thank you, Jennifer. I'm going to put a couple emails, or excuse me, I did put an email address in the chat, and I'm also going to put the website address in the chat, just so that it's right there at you guys' fingertips. And let's see, let me go down a little bit further. Okay, so Michelle, you just wanted contact names for emergent issues. So like I said before, my name is Annette Nguyen. I am the supervisor over the outpatient DME team. And then Nicole Hennifer is the supervisor for the home health team and the behavioral health team. And then our screen team and dental team, our manager, Stacy Knutsvig, is over that team. And let's see, is Nicole over the ABA department? Yes. And Tyler, will you actually put your either a contact phone number or your email address in the chat, and I will give it to Nicole and have her send you her information? And looks like that's all of the questions in the chat for me, unless somebody else has anything.
So Annette, there is another question that says, that says currently auths are 3 weeks out. Is there a plan to get caught up to meet the 7-day turnaround time?
Okay, I totally, oh, it's down a little bit further, I think. So like I said during the slides, we have been monitoring this daily because we were behind. So that is our goal, is to get to that 7-day turnaround time. And as of today, most of the programs were at 8 to 9 days. So we're very, very close. In fact, a lot of the programs are current. but there are also several that are about 11 days behind. So as far as I'm aware, I think the furthest one out is about 12 days. I can actually look right here because we got an update this morning, and it looks like the furthest one behind is the 16th. So 9 days out is the furthest one behind in a program. So we're working very hard at that.
And we really appreciate it.
Thank you.
And lastly, there's a Vincent who has his hand raised. Vincent, do you have a question?
We asked it earlier, thanks.
Oh, perfect. All right. Well, thank you so much. I would now like to introduce Dana. She's going to be telling you about the pharmacy program. Thank you.
Hi there, my name is Dana Boy. I'm a certified pharmacy technician with the Medicaid pharmacy program. And today I'd like to go over the pharmacy program along with some updates that we have. Our pharmacy team is comprised of clinical staff that ensures safe, appropriate, and cost-efficient use of medications for Utah's Medicaid population, determines pharmacy program coverage, pharmacy PA determinations for fee-for-service members, creates pharmacy policy in conjunction with DUR and PNT committees, and interacts with pharmacy providers, prescribers, and members. Pharmacy prior authorization and preferred drug list. So since the fee-for-service Utah Medicaid program and each of the MC has its own preferred drug list or formulary and or PA coverages, if the medication is not carved out of the MCE plan, then the prior authorization needs to be submitted to them. Go ahead and go to the next slide. Throughout the training, there's going to be a few pharmacy PA scenarios that we hope will be helpful to you. One of the questions is a provider needs to request a PA for a member who is enrolled with an MCE. How do I know which PA requests are sent to fee-for-service Medicaid versus a member's MCE plan? So listed here are the select drug classes that are carved out from the MCE, which means that it will be covered by fee-for-service Medicaid. Next. Pharmacy PA forms are reviewed by the clinical staff annually. In some cases, they may be reviewed more often than that. For example, if a drug class gets reviewed in DUR committee or PNT committee before the annual date deadline. And in addition to our pharmacy PA forms, the PDL contains very valuable coverage and policy information. And the list there, the drug criteria limits, round over generic list, OTC drug list, mandatory 3-month supply list, and a list of prior authorization forms. Those are now in one document. Next. A PA has been denied. What are the next steps? So we always provide the denial reasons on the letter, so make sure to review those. If the request was denied for a product that is non-preferred, consider switching to a preferred product. If the request was denied due to lack of documentation, just resubmit the request with the needed information. And if no additional action can be taken, the provider may submit a pre-hearing request with the Administrative Hearings Unit within 30 days. Diagnostic products, including diabetic supplies not listed on the PDL, are non-preferred, and they must be billed through the medical benefit as DME. And the DME PA form is listed there, can be found on our website. HCPCS and NDC crosswalk. Not all pharmacy-related HCPCS codes are listed on the PDL. The Medicaid provider shall verify coverage using the coverage and reimbursement lookup tool every time a service is rendered. And also use the NDC crosswalk using the fee schedule download tool. What is retrospective DUR? It's when the pharmacy staff utilizes communication tools such as motivational interviewing to promote and reinforce best practices in the delivery and administration of pharmacy benefits. The interventions are often determined through a review of claims data or other records, and outcome measures are often derived from CMS guidance as well as NCQA. Next. In the next few slides, we'd like to share with you the retrospective DUR work that the pharmacy team has been working on. One of them is the Attention Deficit Hyperactivity Disorder, effective July 2020. The following edit limitations apply for when a claim for an ADHD stimulant is processed through the pharmacy point of sale system. A PA will be required for use in children under 4 years of age or under 6 years of age for the following medications listed. Antipsychotics in children pharmacy edits. A PA will be required for high-dose limitations for members under 20 years of age, in very young children under 6 years old, for concurrent use of multiple antipsychotics, for high-dose antipsychotics that exceed recommendations as listed on the package insert. Diagnosis codes are required on all initial antipsychotic prescriptions for children, and we do require monitoring of annual metabolic screenings. And you can see that from our pharmacy interventions, the percent of children receiving antipsychotics, number of foster care members, and number of children receiving multiple antipsychotics have decreased. Hepatitis C medication adherence program. It's aimed at increasing treatment completion rates and cure of hepatitis C infection among fee-for-service members. The program was started in April 2020 for fee-for-service members. The baseline in 2019 was 73%, and with our interventions, it has increased significantly. One of our newer retro DUR work is the antidepressant medication adherence program, aimed at improving antidepressant medication adherence for members with newly diagnosed depression. Our clinical pharmacists will conduct outreach to targeted Utah Medicaid fee-for-service members through motivational interviewing techniques to identify barriers to adherence, address health literacy, and create a strategy for change. They may assist the member in ordering medication refills, finding a pharmacy that delivers medications, or connecting them with a health program representative when a member has other needs, and also reach out to the mental health care provider to provide pertinent information, such as member-reported side effects to the antidepressant or refill requests that are needed. And we do follow-up calls to the member for continued medication adherence support. Pharmacy opioid interventions. Since October 2019, there has been a 47% decrease in the number of fee-for-service members on MME greater than 90, decrease of 17.8% overall among all Medicaid members. And since April 2019, there's been a 15% decrease in the number of fee-for-service members with concurrent opioid benzodiazepine use. And we continue to see declines through our interventions in both of these areas. Moving on to pharmacy policy updates. Effective 1/1/21, Utah Medicaid will limit the use of opioid medications in members who are also receiving medications to treat opioid use disorder, or MAT. When a claim for an opioid medication is processed through the pharmacy point of sale system, it will look to identify if a claim for MAT has been processed in the last 45 days. If the system recognizes the claim, it will limit the opioid to a 7-day supply or less. And if there's not one, then the opioid will process without the 7-day limitation, with all quantity and policy limits still applied to it. Also, effective 3/1/21, the opioid use disorder treatment drug class was updated on the PDL. The oral buprenorphine and buprenorphine naloxone products prior authorization form was updated to reflect the approval criteria for quantity limits, dose limits, and non-preferred products. One of the highlights is that no PA will be required for the single ingredient buprenorphine, with a note that all quantity and policy limits still apply to that as well. Pharmacy staff will attempt to contact the provider to switch to a preferred biosimilar product if a PA is received for a non-preferred reference product. And also, the proof of delivery requirement is waived for a non-Schedule II prescription. Effective 5/1/21, continuous glucose monitors are now covered through the pharmacy point of sale system with a prior authorization for children and adults. Please refer to our PDL for a list of preferred products. Effective 5/1/21, our current non-preferred policy requires that a member try and fill at least one preferred agent, but when they actually transition to Medicaid from other payers and they go to the pharmacy, it might result in a rejected or denied claim. In that case, Medicaid has updated the policy to make exceptions for continuation of care for a non-preferred product, which is defined as a member being on the medication for a minimum of 60 days out of the last 90 days, unless the medication was used emergently. Next. Our next scenario is the pharmacy has a rejection for PA required for Ozempic. Ozempic was preferred on Utah's PDL in the past. Why is this now required? And this goes along with other medications as well in this case. Just keep in mind that the PDL coverage is updated monthly, but it will list when the change took place. So for this particular case, the Ozempic is listed as non-preferred under the GLP-1 agonist since 1/1/21. The preferred products are just above it. And a little background, the Ozempic was grandfathered due to the PDL update, so all of the claims after 4/1/21 will require prior authorization. And if the provider is not able to switch to a preferred product for the member, then they can submit a PA for continuation of care. Moving on to pharmacy services updates, we have quite a few. For COVID-19 vaccine administration fees, as of March 15th, 2021, the administration fees increased to $40. Effective 4/1/21, the pharmacy point of sale claims for insulin pens may be billed for up to a 140-day supply with a limit of 1 box for claims over 30 days in accordance with the FDA's recommendation. The day supply on the submitted claim should reflect the actual days the medication will last or expire. For our ADHD stimulant edits in the pharmacy point of sale effective 4/1/21, 3 or more unique ADHD stimulant medications prescribed concurrently or cross-class prescribing of ADHD stimulant medications from amphetamine class and methylphenidate class for at least 30 days in the last 45 days for children under 18 years of age. Next. And our last scenario is the pharmacy has a rejection for a member who is 16 years old and is on an amphetamine and methylphenidate concurrently. What PA form does the provider need to submit? Our PA forms on the website are listed in alphabetical order, either by drug or drug class. In this particular case, you won't find the PA under amphetamine or methylphenidate, but it will be under the ADHD stimulants. And we just ask that providers fill out the form and submit the required documentation for review on all prior authorizations that get submitted. Next. we encourage you to visit and familiarize yourself with our website to find out more information regarding the Utah Medicaid Pharmacy Program. And if you have any further questions, the next slide has the contact information to our customer service, medical policy, pharmacy, and prior authorization. Does anyone have any questions at this time regarding the pharmacy Medicaid program?
Thank you, Dana.
Yep, you're welcome. I'll turn the time over to Elise with OIG.
Good afternoon. My name is Elise Knapper. I'm the UOG's policy analyst and trainer. As I'm sure you're all aware, the statewide provider training today is a little bit different than it's been in years past. Instead of a really in-depth look at each program area, the focus has been on what's new and what's changed. And the upside is that the training today has been a lot shorter than it has been in previous years. Unfortunately, it also means that our office didn't feel like we had enough time to deliver a really effective training or to cover all of the topics that we needed to. So this year, I'm just going to spend a few minutes going over some really high-level information about the office, who we are, what we do, and then I'm going to share some resources that can help assist you with your compliance efforts. And then at the end of the overview, there's some information about how to register for the upcoming UOIG fraud, waste, and abuse trainings, or how to request that we come out to your organization, either in person or virtually, and deliver a training that's geared specifically toward your organization. Next slide. So the Utah Office of Inspector General was formed in 2011 as an independent office. Next slide. What that means is that the office is not under the supervision of, nor does it take direction from any other departments within the state of Utah. Gene Cottrell is our Inspector General. He is the second person to be appointed to the position, and he is currently in his second appointment. The office's goal is to eliminate Medicaid fraud, waste, and abuse. Next slide. We work to achieve our goal by following our mission, which is to protect taxpayer dollars by identifying fraud, abuse, and waste risks and vulnerabilities in the state Medicaid program, and then by taking action to mitigate or eliminate those risks. And we do this in two key ways. One is proactive, where we look at potential policy or procedural opportunities within the program. This is the direction that CMS has recommended. By identifying opportunities to clarify policies or to refine procedures and then proactively addressing them, it helps to contribute to the avoidance of a pay and chase model of business. We feel this is important because a pay and chase model is largely inefficient. It can lead to a lot of waste within the program. So ideally, issues could be identified prior to actually becoming issues, which would save both the UOIG and Medicaid the time, effort, and resources needed to resolve those issues. The other way that we work toward our goal is by looking at causes of improper payments. And that might include things like examining claims history to differentiate between honest mistakes and intentional errors. This is a more responsive approach, but it's also an important component to identifying fraud, waste, and abuse that may be occurring within the program. Next slide. We have oversight over anywhere that Medicaid dollars go. If you look at the radial cluster or the chart on this slide, you can see just how large that oversight universe is. We look at the program funding and sources of revenue from federal and state and county dollars to grants. We look at the divisions and the departments who have responsibility to oversee Medicaid programs. We look at the waivers. We look at Prism. And we look at the providers who are contracted to provide services to Medicaid beneficiaries. So although we have oversight over the entire universe that you see here, the UOIG cannot prosecute criminal conduct. So for that, we work with MFUCU, or the Medicaid Fraud Control Unit, and we refer potential criminal conduct dealing with Medicaid funding to them. Next slide. So just to put all of that into context, these are some really high-level metrics for the last couple of years. Utah Medicaid reports that in fiscal year 2019, total Medicaid expenditures were $2.8 billion, with over 17 million claims or capitations paid. And then in fiscal year 2020, those numbers climbed to 3.3 billion in expenditures and just over 18.3 million claims or capitations. So as you can see, it's a very substantial program. But with that comes some inherent risk of potential fraud, waste, or abuse of resources. Next slide. So we want to be able to gauge our effectiveness as good stewards of taxpayer resources. And in order to do that, we've identified a number of KPIs and metrics that we use as sort of a barometer of our work. Since the state legislature created our office in 2011, we have recouped over $74 million. So the return on investment to taxpayers is very high. And we calculate 3 return on investment numbers. One is recoveries, one is cost avoidance, and then the last is the overall ROI. In 2019, our ROI for recoveries was just over 147%. Our ROI for cost avoidance was 612%. And our total return on investment for taxpayers was 760%. So although last year was something of an anomaly because of COVID, I'm sure that's true for everyone, Utah's ROI for recoveries was 390%. The ROI for cost avoidance was 809%, and the total return on investment for taxpayers was 1,199%. And speaking of recoveries, if you look at the recovery rates for the last few years on this chart, you're going to see a pretty clear trend. And that is that cost avoidance is a very effective way for us to safeguard taxpayer resources. As a result, we place a very strong emphasis on cost avoidance. In case any of you aren't familiar with the term, cost avoidance is best described as a change in behavior, maybe a change in provider billing behaviors, or a change because Medicaid implemented a new policy that we recommended, but some kind of change in behavior that is attributable to our office and then results in quantifiable savings to the Medicaid program. So we calculate cost avoidance by observing trends both prior to a project and then again at the completion of a project. We compare the average difference in billing behavior prior to and after completion, and then we project the associated savings out over 5 years. Our model for cost avoidance has actually been adopted by a growing number of other OIG programs across the country, which we think speaks pretty highly of Dr. Vanos' work. He's our lead data scientist. And it also tells us that we're on the right track. What we feel is really especially important about cost avoidance is its efficiency. As its name suggests, recoupment is part of a pay and chase model of business. So Medicaid has already paid out those monies, and now we have to chase them down and attempt to recover them if they were paid out improperly. Meanwhile, cost avoidance prevents those resources from being inappropriately used or wasted in the first place, which is why we focus on it so much. Next slide. Our office is organizationally divided into 3 distinct program areas. The first is the operations or mission support team. And this is the group that you'll be in contact with regarding general operations, records requests, and hearings. And this is also the team that our data scientists work on. They examine the Medicaid claims universe, they look for trends, potential fraud schemes, and outliers in the data. The next team is the audit team. The auditors follow a very strict audit process with an identified audit plan and stated objectives. And the audits must adhere to quality standards that are set by the United States Government Accountability Office, the Federal Offices of Inspector General, and the Association of Inspectors General. And then last but not least is our program integrity team. And the PI unit is probably the one that works the closest with Medicaid, just as a result of their program integrity responsibilities. They receive complaints from the media, from the public, from individuals who may have reviewed their explanation of benefits, really from all types of sources. They also have several nurse investigators who review medical records, and they're involved in the recoupment or hearing process. Next slide. That brings us to reporting. So if you have any reason to suspect fraud, waste, or abuse, Utah code mandates that you report it to the Utah Office of Inspector General. You may also report suspected fraud to Mafuku, and because each healthcare organization and each state and local government have their own fraud detection policies, you may also be asked to report suspected fraud, waste, or abuse in accordance with your employer's policies to your employer. Next slide. You can report suspected fraud, waste, or abuse to our office through several ways. You can call our hotline, 855-403-7283. You can email a referral form to our office at mpi@utah.gov, or you can go to our website and you can fill out a form online under the Report Fraud tab, and I want to say that's in the upper left corner of the landing page. Also, at the conclusion of training today, I'm going to send out a copy of our referral forms to everybody who registered for the training. Now, speaking of referrals, as a referent, you have the ability to request to remain anonymous when you make a referral. If you request to remain anonymous, we will absolutely honor that request. However, providing us with your name and contact information is sometimes crucial to our ability to pursue a lead. So for example, if we receive a tip and it involves a person with maybe a very common name, and there's a list of potential individuals that the tip could be about, it's very helpful for us to be able to reach out to the referent and ask for some additional identifying information, maybe the person's age or where they live. Something that can help us narrow down that list of potentially involved entities helps us enormously. It's also important to note that even if you do provide us with your name and contact information, we will keep that information strictly confidential. It's not something that we typically share outside of the office. In fact, the only time that we ever release your contact information is if a criminal case necessitates it or a court order compels us to do so. And in the event of a criminal prosecution, we would only share your contact information with Mafuku, who also maintain their own very strict confidentiality policies. Next slide. So compliance. We're often asked questions about what's allowable. And this probably applies to all of the trainers who've spoken today. I know that we welcome those questions. We want to know, and we're happy to assist with them. But we do want you to know that it's not always possible or appropriate for us to answer those questions immediately. And that's because Medicaid programs and policies are incredibly nuanced. Whether or not something is allowable can change based upon the Medicaid program or the waiver in question. It can change based upon the age of the Medicaid beneficiary or other demographic information about the beneficiary. It could change based upon the service or the policy that was in place at the time of the service, the date of the service. It can also change based upon maybe the existence of a prior authorization if a PA was required. So in addition to all of those nuanced pieces of policy, we also want to ensure that we're making very consistent recommendations. We want to be sure that we're providing consistent guidance. So it's very possible that we may take some time to research your questions before we provide you with our official opinion. So this brings me to what is probably our, or at least in my opinion, the most important compliance tip that I can offer you. And that's just to keep in mind that Medicaid policies and regulations change frequently. This last year with COVID, I think, was probably a really good example of that. At one point, federal regulations and the amended 1135 waivers changed sometimes daily. And that resulted in telehealth regulations that also sometimes change daily. As was mentioned earlier, I think your best resources for Utah Medicaid policy are going to be the Medicaid Information Bulletins, or the Mibs, the provider manuals, and Utah administrative rules. I would strongly recommend that you go to Utah Medicaid's website and sign up to receive notification of those Mibs if you haven't already done so. Next question. Or I'm sorry, next slide. Nothing just popped up telling me I had a question. I'll get to those, I promise. I'm sorry. I've got a couple more slides and then we'll dig into all of them. That brings us to training. So in keeping with the duties and powers of our office, we provide training to government employees, to providers, their staff, and to key community partners and stakeholders. We offer an about 50-minute long training on fraud, waste, and abuse, and that assists providers in educating their staff about requirements for providers that are outlined in the Federal False Claims Act, the Deficit Reduction Act, and in your contractual obligations. It also covers some additional topics such as responding to UOIG records requests or how to report to the UOIG, changes resulting from COVID, and information about the recent changes to the ACO contracts, including the new take-back processes. So we have 2 of those trainings coming up. They're actually scheduled for next month on September 8th and September 16th. If you're interested in attending, there's a QR code on this slide and also in your slide deck. If you've got your smartphone handy, you can capture it now and it'll take you straight to the registration page. Or you can go to the hyperlink in your slide deck and that will also take you to the registration page. Or you're welcome to email me or email Alex Franco, and her email address is alexfranco@utah.gov, and I'll plug that into the chat box in just a minute. So in addition to the fraud, waste, and abuse training that we do for providers, that's the big overview, we're also available to provide training to directly to providers or to your respective organization, and then to tailor the content of that training for each audience and their particular training needs. So if you'd like to request that type of training content directly for your organization, please reach out to me and I'll put my contact information in the chat box also. Next slide. So it's also included here, or will be in just a second. The UOIG's management contact information on this next slide is listed here. Jean and Nate are incredibly responsive, and you're welcome to reach out to them or to me with any questions. And that, if you want to, last slide, is all I've got. So let me plug in this contact information. I have to pull up the chat. And then I saw a couple of notifications pop up. I think somebody had their hand raised.
Looks like we have Sarah that has her hand raised.
Okay. Hi, Sarah, what's your question? If you're speaking, you're on mute.
So Elise, while we're waiting for Sarah, you do have a question in the chat. It says, would your department be the ones to address policy information listed on the state's reimbursement tool to make sure policy is being effectively communicated to providers?
Not necessarily. We're not the office who makes policy. That would be Medicaid. We can't make policy for Medicaid, although we do make recommendations. So you're welcome to reach out to us or to Medicaid directly. It really depends upon the specificity of your question, whether or not it's something, if you're looking at whether or not it's allowable, or if you have a very particular instance and you want to know something about that, that kind of changes the answer a little bit. So you're welcome to reach out to us or to them. If it's not one that's for us, I'm happy to refer you, and I'm sure the same is true in the other direction. If you reach out to them and it looks like it's something that's for us, they're really great about sending you back to us.
So Jeanette, you can reach out to customer service for reimbursement tool questions, or you can reach out to policy directly. Lee can help you with that email if you did not get the med policy email, to ask questions for them. If you need that provided, we can go ahead and provide that as well. Again.
Thanks, Emily. It looks like Vincent asked, how do we register for training with your department? So there are a couple of ways. It depends on which training you'd like to come to. The big fraud, waste, and abuse training that we do that helps you meet the requirements in the False Claims Act and the Deficit Reduction Act and in your contracts, that one is happening next month. We have 2 of them scheduled. You can either email me, you can follow the QR code in your slide deck, or you can follow the hyperlink in your slide deck, or you can go to our website under our publications. There's some information there also, and we can get you set up for that. I'm also going to send out an email to everybody with a copy of those referral forms, as I mentioned, and I'll include the training information in that as well, just so it's really handy and easy for you to access. If you're talking about training where we come out to you directly and we tailor it to you, definitely reach out to me specifically, because I'd be the one to do that. And we can talk about your particular training needs and what it is that you'd like us to tailor for you. Are there any other questions? Should I turn it back over to Emily? Okay. Thanks, everybody. I'll turn it back over to Emily.
Thank you, Elise. Well, we thank you for being with us for the 2021 provider training. If you need any additional questions answered, you can call customer service. You can email me directly. If I don't know, I can certainly get your question to the appropriate person that can help you. Other than that, we wish you a good rest of your day, and we'll see you next year.